Hello, and welcome to today's roundtable co-hosted by the Indigenous Journalists Association and the Commonwealth Fund regarding how Indigenous journalists can utilize data from the Commonwealth Fund's Health Equity Scorecard. The scorecard on state health system performance is long-track the functioning of each state's healthcare system with the goal of motivating actions to improve the residents' health and healthcare. Assessing how well a state's health system performs on average can mask profound underlying inequities we'll discuss today, as well as how journalists can investigate the impact of past policies on health across racial and ethnic groups. Our panel moderator is IJA Vice President and ICT News Executive Editor Jourdan Bennett-Begaye. She identifies as Towering House Plan, the Coyote Pass of Jimenez, the Mexican Plan, and the Hopi with Red running into the Water Clan. Jourdan received her master's degree in magazine, newspaper, and online journalism through the Newhouse Minorities Fellowship at the SI Newhouse School of Public Communications at Syracuse University in New York. Her health background is rooted in her bachelor's degree in athletic training from Fort Lewis College and the University of Michigan Future Public Health Leaders Program via the Center for Disease Control and Prevention. Jourdan may take questions from the audience as time allows. Please use the Q&A option at the bottom of your Zoom window to submit a question. Jourdan, take it away.
Hi. Thanks, Sterling. Yeah, to everyone. Thanks for joining us. I'm going to introduce our two panelists. First, we have David C. Radley. He is a senior scientist for the Commonwealth Fund's Tracking Health System Performance Initiative and Director of Data and Analytics at the Center for Evidence-Based Policy at Oregon Health and Sciences University. He is a health sciences researcher with expertise in small area analysis and in the design, implementation, and interpretation of observational studies that take advantage of large administrative and survey-based data sets. Prior to joining the university, he held positions at WESAT, the Institute for Healthcare Improvement, and at Associates. Radley received his Ph.D. in health policy from the Dartmouth Institute for Health Policy and Clinical Practice. He holds a BA from Syracuse University and an M.P.H. from Yale University. We also have our second panelist, Shondiin Silversmith. Shondiin is an award-winning Diné journalist and Indigenous communities reporter for the Arizona Mirror based on the Navajo Nation. Silversmith has covered Indigenous communities for more than 10 years and covers Arizona's 22 federally recognized sovereign tribal nations, as well as national and international Indigenous issues. Her digital, print, and audio stories have been published by USA Today, the Arizona Republic, Navajo Times, and the Ground Truth Project and PRX's The World. Silversmith earned her master's degree in journalism and mass communication in Boston before moving back to Arizona to continue reporting on Indigenous communities. She serves on the board of directors for the Indigenous Journalists Association and has made it a priority in her career to advocate, pitch, and develop stories surrounding Indigenous communities in the newsrooms she works in. Thank you both for being here today. And just for a quick run of show for everyone who's watching, Dave is going to give a presentation for 20 minutes, and we'll talk with Shondiin for 20 minutes about the work that Dave is doing, and then we'll leave it open for Q&A with the audience for about 15 minutes. So Dave, I'll let you take it away from here.
Thanks a lot, Jourdan. I'm going to go ahead and share my screen here, everybody. All right. So you should see the slide deck now. So really grateful for the opportunity to talk with you today and to share results from our Health Equity Scorecard. We'll jump right in, but before I get into the data, I did want to just acknowledge my colleagues at the Commonwealth Fund who were co-authors and collaborators on this report. Lori Zephyrin, Sarah Collins, Neil Poe, Arnav Shah, and Jesse Baumgardner. And also to a lot of the experts who have given us feedback on the methods and on sort of contextualizing all of the really important work that I'm going to show you today. My contact info is here on this slide. I think after the presentation today, we'll be able to share slides with you. So my contact info is here. Both of those email addresses work. So before we get too deep into the Health Equity Scorecard, I wanted to just sort of give a little bit of framing about our our health system scorecards generally. The scorecards have been around for almost 20 years. Our first report came out in 2006. And the general format for these scorecards hasn't really changed much over that time. We look at about 40 to 50 different measures of performance, so that are sort of grouped into different buckets. We look at healthcare access, healthcare quality, avoidable hospital use and cost. We sort of think about these as being measures of efficiency. And of course, we look at population health outcomes, and health equity is a big part of this effort. In the most recent state scorecard, which I won't really talk too much about today, but if you're interested, you can check it out. We also added a new section on reproductive and women's health. It's going to be an emerging area of work for us in the scorecard series. The scorecards generally ask, a couple of different questions, and we use all of these data points to sort of answer these questions about whether or not Americans have good access to care, are they getting the right care at the right time, and how healthy people are. And we look at states as the primary sort of unit of variation, because so much of healthcare is governed by state policy. Each report, at least in sort of its current iteration, has like an online narrative and then a series of state profiles. So we really want to make sure that people are aware of the data that's specific to their own states. So in 2021, sort of rewinding a little bit, going back a few years, I guess it was 2020, we knew that we needed to sort of do a little bit deeper work on health equity across states. The state scorecards are great, but like Sterling said, even at the outset, state averages mask variation that's going on within states. And so sort of knowing this and sort of recognizing that there are just, big disparities, everyone knows about them, just big disparities across states in the way that people experience healthcare, we decided to take a much deeper dive and to do this health equity report. First report came out in 2021. And we're working on an update right now, which will come out in April of this year. So the equity reports are a subset of the measures that we put into our full scorecard that we can stratify by race and ethnicity. We break out these measures of healthcare access, healthcare quality, and health outcomes. And we report them for 5 different racial and ethnic groups. Non-Hispanic Black, non-Hispanic White, non-Hispanic American Indian and Alaska Native, which would be really the focus of what we're talking about here today. We have non-Hispanic Asian American, and then we have Hispanic ethnicity. The data in the 2020 report, we use federal data for this mostly. It's generally a little bit lagged, so it generally reflected what was happening between 2019 and 2020. And I'm going to show you some updated data in this report. The 2024 report will have data that generally reflects 2021 and 2022. That's like, sort of big picture findings I think aren't necessarily a surprise for anybody. We see big disparities in all states, even states that sort of have a reputation for having a relatively strong health systems. States that do well in our full state scorecard, for example. Even in those states, we see big disparities when it comes to the health experience of people of different races and ethnicities. We generally found that the healthcare experience for people of color was markedly worse when compared to whites. And then in the 2021 report, this will change a little bit when we have our final numbers for our 2024 report. But what we found in 2021 was that there were only 6 states that had above average performance for all racial and ethnic groups: Massachusetts, Connecticut, Rhode Island, New York, Hawaii, and Oregon. There were a lot of states, particularly in the Midwest, where they may have had very strong performance for some groups, but relatively low performance for other groups. And then there's a number of states like Mississippi and Oklahoma that really had relatively low performance for all groups in the states. And so this right here, what you're looking at, and I'll go slow on this one. This is where we're going to start getting into some interesting data, I hope. This would have been sort of the summary data for American Indian and Alaska Native populations in the 2021 report. So we had enough data to provide, to sort of create a ranking for 14 states that represented the healthcare experience of American Indian and Alaska Native people in those states. Of those 14 states, California had the highest performance for Indigenous people. And it was the only state where the healthcare experience of Indigenous people was sort of above the national average for everybody. And you can sort of see that in this, and this is just a screenshot of the profile. So it's a screenshot of a PDF. So if it's a little small, I apologize. But this sort of dark gray dot that sort of hovers just to the left of that center line represents better than average performance in California. And then if you sort of look down the rest of the line here, New Mexico, Washington, North Carolina, Oklahoma, and so forth, you can see that health system performance sort of for Indigenous people is lower in each of those states. I think the other key takeaway here is that sort of in aggregate, so this is again looking overall for all of the measures that we have access to. Overall, we see that Indigenous people in each of the states that we could measure had much worse performance than the top performing group in that state. So in California, for example, we'll just take this sort of top line here. In California, the highest performing group would have been Asian Americans. In other words, that represents sort of better access to care, better health outcomes, and receiving better quality care compared to people in other groups. And then you can see there's a sizable gap between the experience of the best performing group and then the lowest performing group, or in this case, the Indigenous people in the state. Oklahoma happened to have the smallest disparity, but that's mostly because the highest performing group in that state, which I believe was white people, don't have particular, health system performance for that group isn't particularly strong either. So the disparity is relatively narrow, but probably for the wrong reason. So just to look at a little bit of a sneak peek for what's coming out in the 2024 report, and please note that any data that I show that's specific to the 2024 report, I am going to have an embargo on the slide. It'll be sort of per slide. Some states will have embargoes and some slides won't. So please just note that if you see some data that looks interesting, if it's embargoed, please wait until the embargo to write.
And the embargo date is at the bottom of the screen, right? Correct?
Yep.
Okay.
Yep. 4/5/2024. That'll be when our 2024 updated report comes out. So, for example, this is going to be the state rankings for American Indian, Alaska Native populations in the 2024 report. North Carolina is going to be on top of that set of rankings, followed by New Mexico and California. You'll have some states in the middle, and then lowest performing states, North Dakota, Alaska, and South Dakota. And so in this map, sort of lighter color represents higher performance, darker color represents lower overall performance. And of course, just like in the 2021 report, we don't necessarily have sufficient data to be able to do a state ranking for Indigenous populations in all 50 states. So these would be the 14 states that we actually can rank on. So let's shift gears a little bit and start talking about some specific measures. Like I said, the scorecard itself is made up of about 25 measures of health system performance, and it's those individual measures that sort of reflect really, what's going on, where's the story. So the most important measure I think that we report is this measure of premature deaths. So these are deaths before age 75 from healthcare conditions that are either treatable when they're identified early, or they're preventable with good primary prevention. So, for example, a death from breast cancer would be considered avoidable in this context. Deaths from COVID would be considered avoidable in this context because we know how to prevent COVID. There's a list of about 80 different diagnoses that sort of make up this list. We didn't invent it. It was made up, it was sort of identified by researchers in the OECD. But we do track the measure. We track it internationally, and we track it for all 50 states. And now we can even track it for different racial and ethnic groups across 50 states. And what we see when we look at this is that sort of looking from left to right across the page here, the orange cluster of dots, each dot is a state, and it represents the state rate of premature mortality. In the orange dots, it's for Asian Americans. In the gray dots, it's for the indigenous populations. The sort of teal dots are for Black people in each state. The yellow dots are for Hispanic people in each state. And the blue dots are for white people in each state. And by the way, I try to keep the same color coding throughout, all of these slides to sort of, help people keep track of what they're looking at. So anyway, when we're thinking about sort of the state averages, what we see is that there's much more variation in premature death rates among indigenous populations than there are for other groups. So in other words, there's the vertical spread for indigenous populations is much wider than it is, say, for Asian Americans. South Dakota had the highest premature mortality rate. Georgia had the lowest, looking at data from 2020 and 2021. I highlighted Arizona and Oklahoma. We had a little pre-conference, and folks thought that those would be some interesting states to highlight. So I've highlighted them where I can throughout some of these slides. Big spread across states in premature mortality rates. But when we take a look at state-specific rates, what you can see is that, in this, it's the same measure, but what you're looking at is the state rate for indigenous populations are the darker color dots that sort of hover above. And then the lighter color dots would be the group in that state with the lowest premature mortality rate. Okay. And we could calculate premature mortality rates for indigenous people in almost every state. Only these small group of states over on the far right, New Hampshire, Delaware, DC, and West Virginia, we couldn't calculate a premature mortality rate for indigenous people. But anyway, for the majority of states, where we could calculate this rate, where there was sufficient data, we see generally pretty large gaps between the experience of indigenous people and the group with the lowest rate in the state. So again, here I've highlighted Oklahoma and Arizona, sort of on the towards the right of the chart. They're sort of on the right of the chart because they've got relatively high rates of premature mortality, among indigenous people, and in those two states, big gaps between the experience of indigenous and then the group with the lowest rate. If you sort of went over to the other side of the chart, to the left side of the chart, Georgia, Illinois, Arkansas, for example, even Texas, relatively small gaps between the experience of indigenous people in those states and then the group with the lowest rate. And even in Georgia, the rate for American Indians was actually lower, was the lowest in the state, which is why you don't see a lighter colored dot there. So if we're thinking about premature mortality, like I said, that's about 80 different diagnoses that sort of make up that measure. So we can start to break that out, and you can see even more variation. We know that diabetes takes a disproportionate toll on indigenous populations, and also on Black people. It's a very prevalent disease. And so I just pulled those numbers out here for Arizona and Oklahoma, and you can see the disparity, particularly in Arizona, where we see Native Americans in Arizona have a much higher rate of deaths related to diabetes than any other group in the state. In Oklahoma, the experience of Native American and Black people is pretty close, and it's much higher than the experience of Hispanic and white people, for example. Another area that we've heard a lot of reporting about over the last handful of years has been deaths from suicide, alcohol, and drug overdose, the so-called SAD deaths. And so I put that data here, and what we're looking at is the trends over time between 2012 and 2021 in death rates for the U.S. population in gray, and for the indigenous population. In this case, the bars are purple. And what you can see is that, well, for all three types of death, suicide, alcohol, and drug overdose, we see big spikes between 2020 and 2021. That's not new. We've sort of known that for a while. I mean, this is, largely, it reflects the stress, the mental health stress associated with the pandemic. And we know the pandemic exacerbated all of these things. but what we see also in this chart is just how disproportionately deaths from alcohol affect Native American populations, and how that really has outpaced other deaths from other types of sad deaths in the most recent in recent years. We'll see if that trend continues when we start getting the 2022 and then eventually the 2023 data. We're going to be curious to look and see how these trends continue to unfold. But these numbers, I've been looking at this kind of stuff for a long time, so it wasn't necessarily surprising, but it's certainly eye-opening. I mentioned at the outset that we're going to be doing a lot more work in reproductive health, where we actually have a whole scorecard for reproductive health planned to come out later this year, probably in July or August. We'll get that released, and so we're going to be taking a much deeper look at health policy issues and measures for reproductive health. But here, I give you a little bit of a preview of that. Here we're looking at maternal mortality rates. I can't break these, by race, ethnicity. I can't break these out by states. Fortunately, there's relatively, few enough maternal mortality deaths where we can't break out by race and by state. So this is just the national data here, but you can see that the maternal mortality experience for Indigenous women is much higher than it is for other groups, and that really represents a big spike between 2020 and 2021. I don't know why that is. That might be an area that if you were interested in doing some additional work, that might be an area that would deserve some attention. And maybe that can come up in the discussion today too. Maybe people do have some insights on that. A big part of the reproductive health scorecard is also going to be infant mortality. And so here we're taking a look at deaths within 1 year per 1,000 live births. And I think sort of similar to what we see in other charts. I mean, on the left-hand side of this chart, we just have the national rates. And you can see there that Black people and Indigenous people have the highest infant mortality rate. Sorry, it says these are percents. They're not percents. These are deaths per 1,000. That was just a formatting bug. Sorry about that. The numbers across this whole chart are not percents. They're just rates. But then I couldn't get state rates for every single state, but for these 10 states or so that I could get data for, you can see the state rates, and you see a lot of variation in infant mortality among Indigenous people across the states that we could observe. So in this case, New Mexico had the lowest rate of infant mortality at 4.8 infant deaths per 1,000 births, compared to South Dakota at 14.5 infant deaths per 1,000 births. So big variation across states. Okay. I'm probably going really fast. I'm sorry about that. But we have lots of time for discussion, so we can come back and look at any of these if you want to. So those were health outcomes. So we always think of sort of health access as being the foundation. You can measure the outcomes; they're important. We have to understand the outcomes, but healthcare access is really where it all starts. Because without good access to care, the quality of care sort of doesn't matter, and we would expect outcomes to suffer. So one of the measures that we always look at is health insurance coverage as like our core measure of healthcare access, and that's what you're looking at here. You're looking at state uninsured rates for adults ages 19 to 64. Here I've got the Indigenous populations in each state highlighted in the dark gray dots, and then the group in the state with the lowest uninsured rate among adults in the light gray dots. Okay, and states are rank ordered based on the experience of the Indigenous people in that state. So in this chart, we see that New York has the lowest uninsured rate at just over 10% among Indigenous people, compared to South Dakota with the highest uninsured rate among Indigenous people, hovering at right around 40%. And then lots of variation in between, again, highlighting Arizona and Oklahoma. I think one of the main takeaways here is that there's no state where we can observe the data. There's no state where the Indigenous population has an uninsured rate that's lower than the lowest in the state. In other words, there's a big disparity in every single state. And so again, maybe an area, from a policy perspective that we think about wanting to dig into a little bit. We know that insurance coverage by itself isn't always enough. In fact, you have to have sort of access to care. It's also about having a place where you can go, a doctor you can call. And so one of the ways that we measure that, this sort of idea of what we call meaningful access to care. I'm sorry, this is adults who skipped care because of cost. I'll get to the other measure on the next slide. So in this case, this is the percent of adults who reported skipping healthcare that they needed to because it was too costly. So nationally, again, this chart is set up similar to the one I showed you before. We've got the national numbers over on the left with state data for the states that I could generate a state estimate, highlighted on the right. So nationally, Indigenous people at 79%. Sorry, I've got on this chart, the wording should say adults who didn't skip care because of cost. A little formatting bug. Sorry about that. I'll fix that up before we send the slides out. So if we sort of think about the inverse of this is the measure that we actually care about. 21% of Indigenous people reported skipping needed care because of cost, and then you can sort of see the state breakout over on the side, with each of those states having slightly lower than 20% of people skipping needed care because of cost. Sorry about that. I put these together too quickly. The other measure that we take a look at is this measure of meaningful access to care. So it's people with a usual source of care. Do you have a doc that you can call? What we're looking at here is, again, the state breakout of states of the Indigenous populations in those states where we could observe the data for people with a usual source of care. And again, here the rates are generally pretty high, but there is some state variation. So better performance on the left. So in North Carolina, Indigenous people, 91% of Indigenous people reported having a usual source of care, compared to 62% of people in New Mexico having a usual source of care. So higher rates are better. We got some variation across states. We also look at uninsured rates among kids. And this one actually did really stand out to me. Generally, uninsured rates among kids are much lower than they are among adults, in large part because of the Medicaid and specifically the CHIP, the Children's Health Insurance Program, really goes a long way to make sure that kids have health insurance coverage. But for Native American kids, the rate of uninsurance is still higher than it is for any other group. And again, for the handful of states that we can observe nationally, we see big variation across those states. So in New Mexico, about 6% of Native kids are uninsured compared to 15% in South Dakota. Again, highlighting Arizona and Oklahoma. So big variation across states. We just can't, a lot of these measures, I think you probably are picking up on this, we just can't observe, there's just not enough data to produce estimates for every race ethnicity group in all states. So a lot of times we're limited to about these handful of states that have large enough Native American populations to be able to produce these measures. And then just one slide here on, these are sort of like our healthcare quality indicators. Again, I'm just highlighting Arizona here, but we could produce the same bar chart for any state where we have sufficient data. But what we're looking at is sort of people's ability to sort of get what we would consider to be high quality care. So a mammogram, breast cancer screening in the sort of specified age range to meet the guidelines. Same with cervical cancer, colon cancer, a flu shot, just sort of going down the line here. Older adults with with the pneumonia vaccine, and then adults with a dental visit. And the key takeaway here is that there's variation in the state of Arizona in the experience of Indigenous people in the state, and then the experience of white people in the state. And in almost all of these measures, you see that Indigenous people in Arizona are less likely to sort of get this effective healthcare, this high quality care. They're less likely to get it than white people are. And there's a little bit of I put Hispanic people in this chart too, because in a state like Arizona that has a large Hispanic population, I thought it would be important to sort of see the comparison. Again, to the extent that some of those outcomes that I showed you at the beginning reflect access to care and then high quality care, you start to see how when you look at a chart like this, you can start to see how some of these pieces sort of fit together. Without having good access, it makes getting high quality care a lot tougher. And then that has impacts on health outcomes. So I did want to just highlight that that's all of the data stuff. Okay. I did want to just highlight a couple of resources that the Commonwealth Fund makes available that I want to make sure you're aware of, because a lot of the data that I just showed you lives in our state health system data center. So if we go to the state health system data center, there's a lot of information there. You can arrange, the data is arranged by state or by topic. And if you were to look at sort of a data by topic, you can break that data out by race, ethnicity. You can see data over, time trends over time. We even have incomes. We even have breakouts by income. There's a lot of different ways that you can look at that data. Again, we can't do race, ethnicity for every single indicator, but we can for a lot of them. And so there's a lot of information in the data center that I would encourage you to take a look at. That's it for me. I'm going to stop sharing and hand it over to Shondiin.
Yeah, thank you so much, Dave. I really appreciate that. It was a lot, but I was like, ooh, as a data nerd, I was like, oh, this is so interesting.
It is a lot, and I intentionally sort of pack a lot into these because I know that no one's going to digest all of it during a call like this, but because this is a living resource, it's a document that you can download, you can take a look at. My goal is really to try to introduce you to as many different sort of aspects of that document as possible, because you're going to be able to go back and reference it. And so if you can get that little bit of an introduction, get a flavor for what's there, I think that sort of sets you up to sort of do the deeper dive.
Oh, it's fantastic. Thank you so much. And then to Shondiin now, I mean, when you're introduced to a huge data set like that or data report, I mean, what are you looking for? What's going through your mind?
So thinking about this, I think one of the biggest things for as a journalist, when you get data, you automatically know that that's not the full story. It's going to supplement and support the story that you are going to work on. So going through all of that technical information is a big part of just trying to find, well, why? Why are these things happening? And as a journalist, it's kind of up to you to kind of dig into those things on why these numbers are looking this way, or why these disparities are occurring, and what type of stories that can come out of them. It made me, especially when he was talking about the infancy death rates, it made me think of the story that Dalton Walker did on for ICT about the pregnancy ward at Phoenix Indian Medical Center closing. And that type of information could have supplemented that report by just giving them a little bit of insight into how a closure like this could have this type of impact, or it could be a result of this. So it's things like that I feel when it comes to data sets like this, and you having, especially it broken down by state, can benefit you as a reporter, because Arizona was mentioned multiple times in a lot of these disparities that are occurring along Indigenous communities. So it kind of makes me think like, okay, well, how can I look at these data points and start thinking of stories to build around them so it can help supplement my reporting?
No, that's so true. I mean, and are there, immediately looking at this, I mean, were there story ideas that immediately came to mind for you in this?
So one of the ones that I was looking at, especially now in terms of how timely it is a lot of what's been impacting Arizona in terms of access to health and access to quality health is what's been going on with the sober living homes situation, in terms of how a lot of Indigenous people have been targeted over the past couple of years to seek services at these homes that end up not being able to serve them the way that they do. But a majority of the people who are being targeted rely on state funded health insurance. So when you look at access to health insurance and disparities that relate to that, what are some of the things that factor into it? So Arizona is one of those top states that have that gap of getting quality healthcare for Indigenous people. And Arizona is home to 22 federally recognized tribes, but also it has two of the largest tribal land masses in the country. It's home to the Navajo Nation as well as the Tohono O'odham Nation. So you have to factor in those type of things when thinking about these type of data sets and what plays into why those are the way that they are. So yeah, I think it'd be interesting to see how Indigenous people access healthcare, or what they believe their options are for healthcare. If they only believe that they only have access to state-funded healthcare, or if they even have a general understanding of what it means to get quality healthcare. Because I think in a lot of Indigenous communities, the automatic assumption and belief is that the only access to healthcare you have is through the Indian Health Service. That is your healthcare. That is where you're going to go to get all your healthcare needs. So that's just what came to the top of my head.
But I think you raised like a definitely important point in looking at the context of a situation, right? Like looking at all the different options and then using that to kind of guide your story too. And painting like the full picture, like you said. Because people don't know what they don't know, right?
Yeah.
But then when we look at the full picture, they know. I was kind of curious about, I mean, because there's so many people always say there's, a lack of data, but then when it comes to, I guess, like the data that's really hard for our communities, like the suicide, alcohol, and what was the other one? There's another like one I think you had in here, maybe it was substance abuse. I don't know, maybe I'm making that up, but the three that was that.
It's drug overdose.
Oh, drug overdose. Yeah. So I'm curious, Shondiin, I know one thing that IJA always, we have our bingo card, right? And we see it in a lot of mainstream newsrooms. How do you use data like that to create a story without framing it as poverty porn? I mean, because that would be definitely hard to do for people who aren't familiar with the communities or who just get introduced to this data and are expected to do a story from that.
And honestly, I think that falls back on the responsibility of the reporter and the context behind the type of story that they want to tell. Because in reality, the way that you are framing these stories and the way that you are wording these stories and presenting that information is how people are going to interpret it. If you frame a story to focus strictly on all of the negative tropes and stereotypes of a community, then that's all people are going to get. But yeah, I think having data like what he called it, you call it sad data, right? The suicide, alcohol abuse, and drug overdose. And like those are realities that are a part of an Indigenous community. But like you said, it comes down to context. How are you going to utilize this data without furthering harm within your own community? And that comes down to you as a reporter and the type of story that you're trying to tell, and the stories of the people that you are trying to tell. I think one of the things, especially because for me, when I've been covering the sober living situation, it's hard for me. I've had family who's been impacted by these homes, and I've gone out with grassroots organizations on the street and seeing how it's impacted Indigenous communities. And like, it's hard, but the way that I frame it in my stories is that you humanize them. It's not, and it's not something that that data can fix. I mean, you can show these numbers and you can show that there are these problems, but what led to them? They are experiencing these things. Indigenous people are experiencing these things for a reason. And that's where I think it's important to remember that context and the way that you are framing and researching your story when it comes to sensitive topics like this. And that's why the bingo card exists in the first place, right? Is to be able to remind you that these are really important things that have impacted Indigenous communities for a millennia. And remember that the way that you present this information and the way that you showcase these topics within your stories will have an impact. And your goal as a journalist is not only to like report facts and accuracy, but also not do harm. So I think when it comes to writing these stories that are including such sensitive data like that have this reality on people, you have to think of the context and the humanity behind it.
No, I think for reminding us of that, because I think sometimes that's what people forget. You know, they're so focused on getting the story, but they're like, no, you're working with humans here, right?
Yeah.
Yeah. I was curious of how, when you work with data and try to, come up with a story about it, how do you showcase it, I guess, in terms of visuals without overwhelming the reader?
Yeah, I think that's a good question. I don't remember a time that I worked very visually with data, because it's always just been that supplement of the overall story. But I think one of the good examples that I can think of is the reparations project that Graham Bial and Graham Brewer and Mary Hughes did for ProPublica. The way that they had all of this intense data, but the way that they shared it in that project was it put it into context, because it was able to break it up by state, but also show you exactly what university or museum had access to Indigenous remains or were safeguarding Indigenous remains from, rather than returning it. So I think it really depends on the type of story that you're trying to tell, and if the data set and the numbers behind the data set are what you want to be the focal point of the story.
True. And then my last question before we go into Q&A with everyone. Oh, when you're working with data, do you usually, I mean, I don't know, I guess, do you usually use like a couple data sets from a couple different entities, or I'm curious like how you try to paint that full picture?
I think it's always good to find a couple of data sets to kind of just see, because everybody collects data differently, and but also everybody interprets it differently. So I think it's always good to see how one data set is collected and then compare it to another, and see if they align in some way. But if they showcase drastic differences, well, then why are they so different? Why are these numbers coming up so different? Maybe because they had access to the different type of data. But I think when it comes to your type of reporting, you know specifically what type of data you are looking for and the type of data sets that you want. So if I was gonna look for Arizona specifically and tribes in Arizona, I would definitely want to see how that data was collected and where where they were utilizing it from. Yeah.
Yeah, true. Okay, so just a reminder to participants out there, if you have a question, please use the Q&A box. And then we'll get those answered. But since you're a journalist, Shondiin, so I was curious if you have any questions for David after like looking at that data set or any curiosities. I mean, I have
Yeah.
so many, but I'll let you do it.
So one of the things that I was thinking about when you were going through it is that you mentioned how you separated the data by points in disparity, where the point was up here and then the national level was down here, especially for health access. I wanted to ask you, what did you guys base your health access data on? Was it just by the amount of people who were being covered by insurance, or was it private insurance or state insurance? That's one of the things that I was curious about.
Yeah, in that particular chart, it's people aged 19 to 64 with any kind of, it's the percent of people who are uninsured. So it's the people who don't have anything. On the other side of anything is you could have public, right? You could have Medicaid, CHIP. You could have Medicare. I mean, Medicare is mostly people 65 and over, but there are some people who get Medicare when they're younger, if they're disabled or something. Could be private insurance from a job or something. It could be if you have military insurance. I think the important caveat though is people, the way that those questions are asked, so we take that information comes from a federal survey called the American Community Survey. In the American Community Survey, when for people who respond that they would get healthcare through the IHS, if they don't have some other insurance sort of to go along with it, just having access to IHS doesn't count as insurance for purpose of that chart. So that's an important caveat that sort of, honestly, we don't get to talk about very often because we don't do conversations like this often enough, but that is an important caveat. So, you know, I think that's sort of reflected in the data, because you see a lot of states, like Arizona is one of them, had a high uninsured rate for Indigenous people, but also a relatively high share of people who say they have a usual source of care. If you sort of went back and compared Arizona on those two slides. And I think what's happening there is you probably have a fair number of people who don't have a formal health insurance through, you know, whatever means, right? But they do have access to an IHS facility. And so in that case, you might look like you're uninsured, but you actually have a place where you can go and get some health care if you needed it. So it's just an important caveat in that particular measure.
Yeah, see, and I think that adds to the context of those data points, because that's right. A lot of Indigenous people rely on IHS, but that doesn't necessarily mean that they are covered by health insurance or seek supplemental health insurance. Yeah. See, yeah.
That's very true. It's very true. And we have a sort of a question in the Q&A from Beth Warden. They asked, I may have missed at the beginning, but David, will you be available for a Zoom interview to discuss specific states once the embargo is lifted? Parentheses, South Dakota.
Yeah, sure. So there's a couple. So yes, the answer is yes. Beth Ann, who another one of my Commonwealth Fund colleagues who's on this call, will sort of, you know, she runs sort of point for all of our media outreach, and we'll be able to talk about that. So, but I think there's an important thing I just want to mention about timing here. When we're talking about the embargo is on the report that we're going to release in April. There's a lot of stuff that I showed you that's not embargoed. I embargoed particular slides. And so if you wanted to talk about, for example, what's going on in South Dakota or some other state between now and April, you know, on the data that's not embargoed, we have a lot of data. If you wanted to talk about that, we certainly could set that up. I'm not available next week, but I'll be back with the week after that. And we can get something set up if you wanted to do that before April to write about data that's already public. If you want to wait for the 2024 report to come out, that'll be in April, and there'll be lots of opportunities. You know, we always have a teleconference when we release a new report. You can always dial into that teleconference. and hear all about it at that time. And then also we're always available after the teleconferences for follow-up.
Awesome. Thank you so much, David. And then we have another question from Melissa. Melissa, I'm sorry, I don't want to butcher her last name. Melissa said, as someone from Wyoming, I couldn't help but notice Wyoming was at the bottom of the list or close to it. How could a journalist start to look at the states who are at the top of the list and pull apart / start to understand some of the reasons why those states have smaller gaps or better outcomes than states like Wyoming or South Dakota?
Yeah, goodness, I think everything Shondiin said. I mean, here's the thing: we can't tell from like this view, the view we take of the data, which we're a small research team. We're based in New York State. Like, we can only know so much about what's going on, and so we really do take a look at the data, but then we really try to hand. But it's really hard to understand why, in the kind of work that we do. It's why we engage with people like you, because there's so much more activity, there's so much more that you can do in terms of, doing that deeper dive, talking to community leaders, talking to health system leaders, talking to policymakers in the state, as trying to investigate, what's going on. Why is the diabetes rate so much higher in my state than in other states? We know that policymakers play a big role here, and so I would encourage you always to sort of engage with policymakers. That matters, and also Medicaid expansion is a big deal. A lot of most states at this point have expanded the Medicaid programs. That really matters, and it really matters in getting people covered. Going back to the last question, it really matters in terms of giving people access to care. And so there are policies that are happening right now that can help explain this. But then everything Shondiin said about sort of going down to that deeper level, getting underneath the number, and understanding the human components of it. Human components is why we do this, and so that we can hand it off.
That's very true. I know that's the first thing I thought. I was like, what are the healthcare policy differences in all these states? That's what I immediately thought. I'm like, I could totally make a whole Google sheet out of that. While we're waiting for another question, I had one for you, David. When I was looking at the data, I saw Native Hawaiians and Pacific Islanders in their own category. In some cases, they're considered Indigenous, and I know it's a conversation that's happening in their own community too. I was curious if there's a way, maybe you mentioned this, but I just want to make sure, to disaggregate that data from them. So like to put in their own groups. So then when we do stories, we can include those groups if they are applicable.
Yeah. Sometimes there is, sometimes there's not. So the way that we've grouped for our purposes in reporting in these reports, we've got the 5 groups, where Asian American, Native Hawaiian, Pacific Islander is one group, and then American Indian, Alaska Native is another group. Those groupings generally are driven by the data sources that we draw from. The data sources are getting better on this, giving more ways to differentiate. But we rely mostly on federal data. Okay, so a lot of the federal data sources, again, getting better, but especially if you go back a few years, that was how that's how people were grouped in those federal data sources. When they have like the 6 category, well, actually now they're expanding their categories in most of the different federal data sets, CDC, census, and so forth. They're getting much better. But the short answer is, in the report that I have, the answer is no. We had to pull the data out of the sources that we pulled it from. And so that's sort of like how we had to pull it. Because when we're combining across different data sets, we sort of have to go with the lowest common denominator, which is sort of the unfortunate situation of sort of being the data aggregator, which is the role that I play. If you were to go to some specific sources, like you, for example, if you're curious, you know, a lot of my data comes from a data tool called CDC Wonder. It's a really user-friendly, like, you know, dashboardy thing on the CDC website that users can sort of click through and get estimates for things. That actually does allow, that tool does allow you to break out Native Hawaiian from the rest of Asian American. And so in that case, yes, like somebody, you know, like in your shoes could actually break it out, going back to that source. But because we have to combine with other data sources that don't necessarily give you that level of flexibility, we're sort of stuck.
No, that's very understandable. And can you explain to people like what data sources you pulled from? Because I saw some of them, correct me if I'm wrong, were American Community Survey, the National Vital Statistics, and the Behavioral Risk Factor Surveillance System. Were there other sources I missed?
Those are the big ones. Vital statistics and vital statistics, we sort of access a couple of different ways. One of them is through CDC Wonder, again, that online dashboard. Another one is we actually get restricted use microdata from CDC to do some of this work. And then their behavioral risk factor surveillance system, that's a federal state partnership where it's a survey of about 400,000 people each year. So it's a large enough survey that you can start to break things down. We also use, wasn't necessarily reflected in what I showed you today, but we also use data from Medicare claims. We have access to administrative data like that that would reflect the experience of Medicare beneficiaries. The part of the problem there, and which is why I didn't feature it here, is some of these other data sources, particularly some of the administrative data sources, they're not very good at getting into the different race categories very well. Sort of the common sort of, it's sort of commonly accepted that like an insurance claims database is generally pretty safe for Black, white, but as soon as you get into Asian American or Indigenous, they're just so much, they're just not reliable. A lot of them will have those fields, but and there's low confidence on those fields and some of the other administrative data sets. And I should have said this at the outset, I'll say it now. This is also, to the extent that we're sort of reporting, being, able to sort of put people into different groupings for a report like this, it's all based on their self-report. It's how they identify. I identify as, a white person. And so when I fill out a questionnaire, if I'm asked, like I've filled out the American Community Survey, I put on that I'm non-Hispanic white. I mean, but I'm self-identifying as that. And so all of these data sources that we're talking about here, with the exception of vital statistics, that one's a little funnier. It's all self-reported. On the vital statistics, particularly on like the maternal mortality or infant mortality, it has to do with what the mother identifies as, on the birth record, for example, for a birth certificate, that kind of thing.
Okay. Oh, thank you. And then Shondiin, one last question before we end the webinar. How can journalists make a story of all this data?
I think the way that a journalist can approach this is finding a data set or a data point that they're interested, and then just looking behind why that exists and why it is appearing the way that it is, because like David said, that they're not adding the human component behind this information. They collected all of these data points so journalists could find that human component, can find that why these are appearing the way that they are. And the fact that this particular data set is divided and separated the way that it is by looking at state or certain type of disparity, I think really is helpful, because it kind of gives a journalist a little bit of direction, because then you can start forming your own questions behind, like, okay, well, why is this gap between Arizona and New Mexico so big? Or why is California part of this area, and and then Arizona is way over here. And it just brings up all of these things that you can start looking into, because all of the states that were pointed out have high populations of Indigenous people and have multiple tribes that call that state home. So, and that's why I think I think it's also important to remember that this is data that was collected from 2020 to 2021. So that is something to keep in mind as well, because there was something happening during that time that could have impacted the way that these numbers are occurring. So that in itself is a question, because I mean, especially when you look at the SAD data, you saw those spikes happen in that area before, because when you look at the data points before, they were kind of just very linear, but now you saw that massive spike during that very vital time of everybody's lives during the pandemic. That in itself is an explanation and could be a story behind that too. So I think, yeah, when it comes to looking at big data sets like this, as a journalist, you just start asking questions and start getting curious about the way that you can apply this to the community you cover, but also your own interests.
Oh, absolutely. We are at time. We had two questions come into last minute, but again, I'm trying to respect everyone's time, so I'm gonna have to turn it over to Sterling, and maybe I can send maybe David, like, these questions to you, or maybe IJA has an idea of how to answer those.
Sure, you're welcome to send questions to me, and I'm gonna send a slightly modified, edited, fix my little errors. I'm gonna send out a revised version of the slides that you're welcome to share with anyone on the call.
Perfect. Thank you so much, and I'll kick it back to Sterling.
Yeah, I got a screenshot of those questions just in case. Thank you, Jourdan and Mado, again to our panelists. We appreciate their time and expertise. This concludes today's virtual roundtable, and please keep an eye on IJA channels for the recording. We'll see you next time.